another episode of the 2020 podcast, Canada's #1 optometry podcast. I am your host, Dr. Harbir Sayan. Thank you so much for taking the time to join us here, as always, to learn and to grow. I'm always so grateful for all the support, all the liking, sharing, commenting, and when I see everybody in person, when you tell me about the podcast, it really means so much. So thank you for all the support. And as always, I'm going to ask a big favor right off the top. If you get some value from this conversation or any of the conversations that we have, please do share it. Put a screenshot on Instagram, put a link on LinkedIn, send a text message to your friend, let them know we're having these conversations so we can continue to grow the profession and build a profession and make it thrive. So thanks for all the support. And I'm super excited to have a returning guest, my absolutely wonderful friend, Dr. Mila Ioussifova, who is an absolute elite dry eye expert. And we're going to dive into some of her amazing things that she's doing. Also a trained nutritionist. And practice owner at South Waterfront Eye Care in Portland, Oregon. Thanks again for being here.
Thanks for having me.
I'm glad we get to do this in person this time.
I know.
Last time we did it recorded. Yeah. I'm very excited. And last time I felt like we rushed a little bit, unfortunately. I think the timing was a little tricky. And, we talked a lot about nutrition because you're so heavy into that and the value of that in eye care.
Yeah.
And obviously you're a dry eye expert. Oh, before we go into this, I want to say, I keep forgetting every time, all the interviews we recorded here, I keep forgetting to say off the top, big thanks to the Dry Eye Summit. We are here in Toronto for the Dry Eye Summit. And I want to say big thanks to the team for giving us the space to record these podcasts. And speaking of the Dry Eye Summit, you were literally just on stage.
Yes.
You just came off the stage.
Yes.
And you were speaking. What were you talking about here?
Yeah, so this is one of my favorite conferences. This is my third year lecturing here, and it is so just jam-packed with amazing speakers and amazing topics. So my topic, I actually co-presented with Dr. Manya Madan, and
great.
we did advanced treatments, biologics. So we talked about what's new in the pharmaceutical, but also in the biologic. We talked about autologous serum, PRP, PRGF, all those fun things, and membranes and things like that.
To really nerd out. You get to do that. You get to properly nerd out at this conference because people who are here are really into it.
Yes.
Right. If you're doing that at some a more generalized optometry conference, then there's going to be people who are like, well, this is way above my head here.
Yes.
But when they come here, they expect this kind of thing.
Yes. Yeah.
And you guys, yourself and Manya, are really at the forefront of these types of things: autologous serum, PRP, all this kind of stuff.
Yeah.
So very cool.
Yeah, it's fun because, as you know, I make autologous serum and autologous PRP in my office. So we do in-office blood draws and we prepare the drops in the office. And Manya she only does PRP. So it was nice discussion. And then because those are the questions we always have. Which one is better? How do you choose this or the other? So it was nice to kind of have two different perspectives of when you have access to both, how do you choose that when you're versus when you're only utilizing this? So that was the first lecture. The second one, and we had a panel discussion with Richard and Mark Holmstein and Richard Maharaj.
That must have been fun.
It was fun. It was fun to just cover all the burning sort of topics in it was demystifying myths, things that we hear. Whether this works, that doesn't work. How do we do this and that? So it was great. It was fun discussion.
That seems like it would have been. Sorry, I missed that one too. I've been sitting in this room all day recording podcasts. I should have been in the lectures, especially these amazing.
They're recorded, so yes, you can watch them later.
Are you speaking tomorrow or is it just today?
No, I'm done. So my last one was just before I went. Right afterwards, I went upstairs and changed and came back. But I was the one that I did by myself was on nutrition, which is, as you know, I'm very passionate about. So last year when I was here, I did a whole talk on the gut microbiome and dry eye. So it was very heavy on the gut microbiome. Today's talk was an hour long, and it was everything that we know that's evidence-based in nutrition to dry eye. So a lot of the information was taken from the TIFAS lifestyle report. The nutrition subcommittee had robust data on what do we know? What's the strong evidence on specific macro and macronutrients and micronutrient deficiencies? And is there sufficient evidence that they're linked to dry eye? So I really dissected sort of things, things to look for and things that we can order and do ourselves. And then, of course, I did have, TIFAS also had a section on microbiome. So I dove a little bit deeper. Again, not as much as last year because I had more time, but a little bit more on just the role of microbiome on our immune system and how the microbiome really modulates our immune system, really trains our immune cells to either be upregulated or downregulated. So it's an area of medicine that's just exploding outside of eye care. We know that the gut microbiome now has been linked to every non-communicable disease, every single one. I mean, almost. So when we're talking about, metabolic health, metabolic disease, we cannot talk about that without the role of microbiome. Autoimmune, big one. Patients with autoimmune disease, 100% they have some sort of gut dysbiosis, things like that. So as dry eye doctors, we are seeing these patients in our chair who may not be responding to treatments. You have them on immunomodulators, you're doing in-office treatments. This is why I got interested in dry eye, because I was like, there's more to the story. There's more to this than I'm missing it because I'm doing everything. They're not getting better. What else is missing? And then again, a lot of these patients really, even if they're diagnosed with those conditions, even gut problems, they don't have the right tools or support from their primary care doctors to know how to navigate that world of nutrition. So I went back to school about right before COVID in 2019, and it took me almost 4 years to actually get the training and get so on top of doing the didactic work, I had to do also 1,000 clinical hours. So I had to work with either naturopathic doctor or a certified nutrition specialist and work with patients and cases and things like that. So it was kind of like how in school we do our clinical work. So there was the clinical work aspect that took a while to get through because there's like very detailed documentations and things like that. And then also taking the board exam, which was a 4-hour board exam. Oh my
God.
So
that's a lot.
Yeah.
Holy cow. So you went back and got a proper certification, just like similar if you became any other certified professional. That's amazing. So let's talk about some of that. First of all, the micronutrient thing. Is there some key ones that you can share? Because patients will come in all the time like, is there something I can eat or eat differently or, that would help my eyes? Anything that you could share there, kind of a high level stuff that when we're talking to our patients, we can say you should look out for this? Yeah. So the strongest evidence we have for the micronutrient deficiencies in dry eye is vitamin A deficiency, vitamin C, vitamin B12, and vitamin D. And I went into each sort of those micronutrients and what their role is in dry eye and how they're involved in immune and regulation and things like that. But vitamin D is the important one that I spend a little bit more time because I'm really passionate about it. It is something that vitamin D is, as you know, it's actually a hormone. So it does a lot in our body and it really is involved in modulating our immune system, both innate and adaptive immune system. So, and I do in-office testing. So there's actually vitamin D.
Yes. So there is, and I asked the audience, how many of you know your vitamin D levels? And it was probably around 20%, very low.
That's higher than I would have guessed.
Yeah, maybe it was low. I mean, I just kind of glanced, or lower than that. I just glanced in the audience, so not too many.
Not many, yeah.
But yeah, this is something our patients don't know.
So, what is a vitamin D test? How do you test it? Like a pinprick type of deal?
Okay. Yeah. So it's a finger prick. It's a kit. My technician collects the sample, and then we ship it to the lab.
I gotcha.
It gets processed, and within a week we get the results, and the patient gets the result as well. What's interesting,
do you charge patients for this test?
Yes.
Okay.
Yeah.
Sorry, go on.
And it's actually much cheaper than going to a lab. Vitamin D testing, which in Canada may be different, in US it's very expensive. You get it tested once, and then a lot of times the insurance companies will not cover to retest it. I've paid over, I think it was like $260 in the past, years ago, when I wanted to retest it. So the insurance will cover it once. So it's very expensive to test for whatever reason. But what we do in office is very affordable. And so a lot of patients are like, yeah, like I want to do that. But ultimately, patients that are already even taking vitamin D, I was sharing some of the results from my actual patients, and they were very, very low.
Oh, interesting.
Much
and
lower
generally
than,
they're like healthy patients, like you'd say?
They're healthy patients, and they say, oh, they always say my last blood work was normal. Like they say everything was normal. And you're like, let me really look into it. So vitamin D doesn't get retested, and a lot of these patients, again, they need a higher dose, or I had one patient who actually was in a toxic level, so I had to take her off the vitamin because it's
too high.
Yeah, it's vitamin D is a fat soluble vitamin, so we don't excrete it. It stays in our system.
ADEK.
Exactly. Yeah.
I remember something.
Yeah, you do know. So anyway, that's a big one, to really test vitamin D levels in all of your dry eye patients, especially if they have autoimmune conditions, because it's such a powerful immunomodulator. It plays such a big role in our immune system.
So on the vitamin D thing again, so let's say you do the test and they're low. What are you asking them to supplement? Are they just buying like whatever little vitamin D tablets off of the shelf, like a whatever brand, or is there a specific one that you're recommending?
Yeah, so I approach nutraceuticals as prescriptions. So I actually prescribe. I don't say I recommend this fish oil, I recommend that. I say you're deficient in this, so I'm going to prescribe some vitamin D to you. And I use FullScript, which is a distributor of nutraceuticals. So instead of having all the, as you know, the compliance really drops when you don't have patients. If you tell patients go to a store and buy eye drops or whatever, so you either have to give them specific of what they need, or provide it from your office.
Yes. So you sell it in your office.
So we use FullScript, which is an online distributor.
Oh, I see.
And instead of, because I prescribe so many different nutraceuticals, it would be impossible for me to stock everything, right?
Got it.
So I don't want to do that, because also dosing, I may change. I may prescribe 2,000 IUs for one patient, 10,000 IUs for the other one. I mean, I don't go that high usually.
Okay.
Yeah, so again, I can't really have every single dose in the office. So FullScript is a online distributing sort of company that you can buy wholesale. So you can buy it for yourself and sell it if you want, or you prescribe it from there, and the patient gets an email. They buy it, and you get a little bit of a,
like the profit or whatever from that.
Yeah.
Okay. So, and in the vitamin D, is it a tablet, or is it an oil, like a liquid version of it? Is there a preference that you have? I'm just curious. This is a more personal question.
Yeah.
But so let me give you a slight bit of context. So, I take vitamin D on and off fairly regularly, but like I would always take they come in these little white tablets, right? And 1,000 IU per tablet or whatever. Take 1 or 2 of those every day. And then more recently, about a year ago, I started taking AG1, the greens drink, and that came with the little vitamin D
liquid.
D plus, what does it come with?
D and K,
right? And so it's a liquid one.
Yeah.
And so I wondered, is the liquid more effective?
Yeah.
There's a difference in quality, I imagine, between some of the more kind of the ones you just find over the shelf. So just this is, I guess, more of a personal question, just going more into the vitamin D. Is there something that you'd suggest there?
Yeah, so liquid, if they come in capsule, which for some patients, like a small capsule is easier, and so it's not tablet, it's a capsule, it's a soft gel capsule, or soft gels, I guess, not capsule, but they're soft gels, so it's liquid inside. So those are, and they're really small, so they're easy for some patients. I do like liquid, especially for kids. I use liquid as well. But yeah, make sure that it's D3, and I like K with it for sure. And even with my dry eye patient, there is a supplement that has vitamin A in it as well, because that was another thing that we have, again, from Tifa's report. We know that vitamin A deficiency is highly associated with dry eye.
Right. But vitamin A deficiency is not that common for us here, right?
Yes. So it's not as common, and I actually had a slide on that. But it is something becoming a little bit, we should still think about it, because you can have vitamin A deficiency if you're super restricted. And there's, people that go through some crazy, so some crazy diets where they're really, some patients can only tolerate a handful of different foods because they have gastrointestinal problems. So they may be deficient because they're actually not getting the nutrient from their diet.
Right.
Also, a big thing that I noticed is in a bariatric surgery. So patients that have bariatric surgery, their absorption reduces significantly. So again, it's probably not as common as we thought, but it is also not as common as vitamin D deficiency, that's for sure.
Got it. So what other things did you talk about in your lecture?
Yeah, so we talked about inflammation. So again, linking back to sort of like the whole systemic inflammation. We talked about some of the things that I do now that are non-traditional, like low dose naltrexone, LDN, for
low dose
naltrexone, which is a compounded medication that is used in autoimmune conditions.
Oh, okay.
And it reduces systemic inflammation, but it's also neuroprotective. So patients with neuropathic naltrexone, yeah.
Okay.
So naltrexone is a opioid antagonist. So it is.
I was going to say, is that the same one they use for overdose? Because
yes,
that's what it's sounding like. Okay.
Yes, but at 50 milligrams. We're talking like 0.5 milligrams to up to 4 milligrams.
Okay.
So at a low dose, it actually provides anti-inflammatory effects. Patients with fibromyalgia. So I use this for my patients with neuropathic pain, with systemic or central nervous system, involvement. And a lot of these patients actually have neuroinflammation. So their systemic or central nervous system is somewhat inflamed. So again, fibromyalgia patients, autoimmune patients fall into that. So we talked a little bit about that. Again, more advanced sort of treatments.
That's very advanced.
Yeah.
Are you prescribing that yourself?
Yeah,
You can prescribe naltrexone.
Yeah.
Interesting.
Yeah.
So that's a big difference between Canadian optometry and in the States. Obviously, from state to state, province to province, there's differences. But I mean, in BC, for example, we still cannot prescribe any orals.
Wow.
So we're behind.
Yeah.
But that's pretty impressive stuff. Yeah. That's really definitely cutting edge stuff as far as dry eye treatments go.
Yeah. But some of the other, to answer your question, some of more traditional treatments that we talked about is,
those are boring. We don't. I'm just kidding. No, go on.
But more like, I guess, real clinical applications that you can have is some of the new eye drop, again, not available in Canada, but the perfluorohexyloctanes and then MIBO.
MIBO.
Yes, and then also the new cyclosporin with
we can say brand names.
Okay, that's
yeah.
With
nobody's paying for this. Nobody's sponsoring.
Vivi.
Okay. Which is by who?
Vivi. It's I forget who.
Okay. That's the new cyclosporin?
Yes.
Oh, interesting. So there's something else. And what's the concentration on that?
It's 0.1%.
Similar to Sequel then.
That's 0.09, yes. Okay. So 0.1%. But the difference is that it's the vehicle. So it has perfluorobutylpentane, which is another molecule, semi-fluorinated molecule. So as you know, cyclosporin does not like water, so it's hydrophobic, which is why it's been challenging to get it on the ocular surface. Okay. In this formulation, it stays on the ocular surface longer, so it has a longer residence time, and it spreads it evenly on the ocular surface. So I'm seeing really good results with it, and it's well tolerated.
Very cool. So there was one called Rosacea that was also a 1%. Have you ever heard of that one, Rosacea? I don't know if that was only in Canada or I don't think actually it was maybe not in the States, but it was only indicated, weirdly enough, for like, what was the condition in kids? Like an EKC or something like that in kids. And I was like, it's cyclosporin. And I had samples. I would put my dry eye patients on it. It was actually quite good.
Yeah.
But I don't know if it's still available. And I don't think they ever got the approval for dry eye, indicated for dry eye. So we stopped using it.
It'd be easy to get approved since cyclosporin has been approved in other forms.
That was very interesting. So maybe it had something to do with the vehicle or something else in it. But so this one's called Vivi or something.
Vivi,
Okay, so that's something to look out for as well.
And then the other thing is lotilaner, Xdemvy. Xdemvy has been just such a game changer.
Really?
It's been such a game changer in Demodex population. As you know, Demodex is very, very prevalent.
Is it real? I didn't even know. I'm just
kidding.
I overheard
so
Mark Blumenstein was on stage earlier. I just overheard him, or I'd popped in briefly, and he was like, well, why are people like, where Demodex just all of a sudden showed up? Because there's so much conversation about it now, right? And I was like, you know what? I think I found myself asking that question a few years ago. I was like, why all of a sudden are we talking about Demodex?
Because we're looking, and I think, I don't know. I mean, it is. I know that, like, I probably prescribe in one day 5 prescriptions.
Wow.
Yes. Okay. Like, I prescribe this a lot. Any collarettes I see, which is pathognomonic.
Anytime you see collarettes.
Yeah. If you see collarette, you know this is Demodex. And it's so prevalent. In majority of your blepharitis patients are going to have Demodex. So if you see blepharitis, it's most likely Demodex.
Gotcha.
High percent. I don't know, like something like 80% or something like that.
Wow. Okay.
It's also very, very prevalent in rosacea. You know, the papulopustular rosacea, the one that has like acne-like rosacea. These are the patients that come to you saying that, oh, I never had acne before when I was younger. Now I have breakouts all the time. It's actually rosacea.
I see.
So they have infestation of Demodex on their face. 89% or something crazy, like 90% of rosacea, that type of rosacea, papulopustular rosacea, will have Demodex infestation. So look for the signs on the lids. And then the other type, which is the erythema telangiectatic, the more general redness on the cheeks and nose, that one's a little like lower percent, 50%, but you're still going to see high correlation of Demodex in these patients.
So in the case of like that person who's got the higher percentage of Demodex with the rosacea, is there what kind of treatment is that person generally getting? Are they seeing a dermatologist for that first of all?
No, a lot of times these patients don't even know.
Oh, I see.
They're not, either they are not diagnosed with rosacea, or if they are diagnosed, they're not actually being treated properly. They just
what would the treatment be then? Is there
a lot of times
cream?
Well, yes. So they are ivermectin creams. So there's compounded. So a lot of times their dermatologists are managing this with doxycycline, unfortunately. So rosacea, they'll just manage it with doxy, which reduces inflammation. It doesn't kill Demodex, but it reduces inflammation, so their skin looks better.
Got it.
But then they go on like still to have breakouts and things, so they just sort of manage it. They do topical creams and things like that, which I also will do compounded ivermectin for patients that if they've gone through IPL treatments, which, as you know, also eradicates or it kills them. It doesn't eradicate them. So it kills it works on their skeleton of the Demodex. So it works on sort of frying them, but it doesn't kill the mites, the eggs of the mites, which is why XDEMVY is so powerful, because we're not just treating the collarettes or like, you know, the actual grown Demodex. It actually kills the eggs as well.
Got it.
And what I'm noticing is after patients, and it's twice a day, so it's nice that it's not forever. It's only 6-week course. So that's my first line of treatment now. I'm not starting with like wipes and things like that. I might still do those things, but I always start with XDEMVY. And when patients come back, I notice, you know, such a good efficacy. Most of them completely resolved or improved significantly. Every now and then I'll do another course of it, but a lot of times just one is enough. And they now have not only the blepharitis improved, but the eyelid inflammation looks better. And they actually had that in their studies too, that there's improvement of the erythema on the lids, and meibomian gland expressibility improves. So when I'm pushing on the glands, because these mites, they migrate into the glands, right? So they're not just on the lashes, they're actually inside of the meibomian glands. So, and the eye drop actually gets them in the glands. So glands will start working better once you've done the course of XDEMVY and eradicated the...
Very interesting. I guess it all makes sense. That totally makes sense. So, I have no exposure to XDEMVY because it's not here in Canada. So I know nothing about it. So it's an eye drop?
Yes.
Okay. Twice a day?
Twice a day.
6 weeks?
Yes.
Okay. And then in general, like obviously insurances and stuff are different here too, but is it generally covered by insurance for patients?
Yes.
Yep. Okay.
Yeah. We have pretty good coverage.
So I'm looking forward to that coming out here, because that will certainly change the game, you know, as you said, like as far as treating blepharitis, but even MGD. Very cool. Very interesting. So I know you have the little wiggly mite dummy thing in your office, whatever that is. And do you show that to patients? I
actually do better than that.
You do better than that? Go on.
So I have a little microscope with a little digital screen. So I epilate an eyelash, put it on the microscope, and the digital screen, the patient can see their own Demodex wiggling around on the screen. So patients are, you know, that
What's
shock
the magnification?
factor,
to be able to see
40.
Oh, really?
40x,
I guess more. Okay.
Yeah. So you just, this is on Amazon. It's like a best $200 investment ever. Yeah, I can share which one I use.
If we'll put the link in the show notes, but do you remember what it's called, even if somebody wanted to just Google it or something?
No, I'll have to look it up. I don't remember the brand.
Okay. We'll put a link.
Yeah, it's super easy to use, and it works again, the shock factor. It's one thing for you to tell, even if you take pictures of the lashes, they just see some crust and you say those are mites, that doesn't register. They're like, what? Yeah, they may be like, what? But for them to actually see movement, actually see legs.
That's crazy.
8 legs and then the tail actually
Nasty.
moving around.
Oh my gosh. Even for me, like I've seen, I think maybe you posted stuff for other people. I'm like, that's
Yeah.
crazy that lives on your eyelashes.
Yes. So the compliance improves, of course. Patients,
goodness.
the first thing they say, get these off of my eyes.
No kidding.
I'll do whatever it takes.
Incredible.
So that works. For some patients, I could tell they may not respond well to that, so I may not show it. So
sure.
It's
I can see some people maybe passing out.
Yeah. Well, I've never had that, but usually patients, I'll ask them like, do you want to see it? And usually they're like, yes. So they don't want to see it, but they're also very curious. So then I'll show it to them. Yeah.
People, for whatever reason, actually, I was talking to Alexa about this. Alexa Heck was, we were recording earlier, and she's like, people just love seeing gross stuff.
Yeah.
Right? Like, people love seeing the gland expression. That's why Dr. Pimple Popper became such a big thing. Like, people love seeing gross things.
Yeah.
It's a weird, I don't know what it is, like habit or whatever people have is to see gross things like that. But that's good that you show them.
Yeah.
And go on. What I wanted to ask you, and you can answer it later if you want to share something else, but like we don't have XDEMVY here. So what could I do for Demodex that's not that?
Well, one of the myth-busting topics that we had was on, how efficacious is tea tree? Is it bad? Is it good? And my take on it is that it works. We have good evidence that it works against Demodex. Some of the sort of the cons we've heard about is how it could be damaging to the meibomian glands. But the 2 studies that we have on that is in vitro studies. So there are meibomian glands in the petri dish that put a high dose of tea tree, and it's not real life. And so no in vivo studies have shown that tea tree is damaging to the meibomian gland. So so before XDEMVY was available, my protocol was to put them on like Cleardex for 6 weeks, and morning and night. That the advanced formula. So that's the one that really gets rid of them. Then the patient comes back, and if it's under control, now put them on Zacuvibes or like a hypochlorous spray, something to maintain it, because we know that they come back. If patient cannot tolerate tea tree,
the Cleardex is strong, right?
It's strong. So if they can tolerate tea tree, then going with Zacuvibes is definitely a good option. But I would also do in-office blepharosphere exfoliation, right? So it doesn't kill, it just kind of removes the collarette. So Blefex or Zest, we do both of those in our office. Zest tends to be a better option and better tolerated. But for some patients, you kind of need that little bit more.
Force. I got you.
Yeah.
The
but also IPL.
Okay. Oh, right.
IPL.
Of course. Right. So IPL, and you're an IPL master. So with IPL, I want to go back to tea tree in a second. Just remind me, okay? But with the IPL, so are we just doing like standard, like you put shields in, you're doing treating as close to the lid line as you can get. Obviously, you don't want to get right on lashes, but as close as you can. And that energy is enough to kill some of the Demodex?
Yes.
Okay.
Probably not all, but it helps. Again, it's not going to be your only treatment. So still having eyelid hygiene to supplement with that. And then again, just sort of managing it. And as we know, they can come back. So making sure that patients have maintenance schedule, every whatever you determine, if they need to be having like in-office blepharosphere exfoliation with IPL, maybe that's their maintenance, and then they do some eyelid hygiene at home. Got it.
Okay, so tea tree. I understand not that long ago there was, and you're mentioning there's some debate on it, but that debate was quite like, there was people who had sort of strong opinions on either side. Am I right about that, first of all?
Yes.
Okay. And you were sort of like, no, that was more of an IPL debate. I feel like you're having with somebody else. Did you speak to somebody on stage about the benefits of one thing versus another? Never mind.
I feel like
were you with Toyos or something on stage? Were you guys talking about, what was that? More IPL?
I don't remember, but I feel like even
you
today...
had beef with somebody, is my point. Is what
I feel like today I did too. There's always somebody... I'm always like, yes.
I was dancing around it, but now let's just see. Who do you have beef with these days?
No one.
Well, I can't imagine anybody having beef with you. You're too nice. But the tea tree oil debate, I thought got kind of like heated, and I don't get it though. Like, was that at all? Is like some people are saying, oh, it's damaging to the glands, and some people
Yes.
do you think there was some vested interest in like some companies who sell it and want to like promote it, and others were against it for some reason? Was there any of that?
There's always that, I think. Yes. But we have to go by evidence, right? What's the evidence? And yes, those studies that came out, they were concerning. And I think everybody just sort of panicked and stopped. I mean, I remember going to lectures right after it, and the presenters was like, you guys are not doing tea tree anymore, right? Did you hear about that study? Like, it's very damaging. We've been damaging. Like, there's very much like that, the fear mongering going on. Where if you look at the studies, again, whenever we present it with data, like we have to see, is it a viable? Does it really, do we need a reason to be concerned? And again, the only things we have is in vitro studies in petri dish, high concentration of tea tree on Demodex or on meibomian glands that have been in the free space. So of course they're going to be, they're going to be, so no more studies have come out that I know of, and maybe, somebody will correct me, that's really shown that, yes, this is definitely something that is ongoing, evidence for this, and that we need to step back. So my approach, again, I don't keep patients on long-term anymore, but I'm not shy to start with it. So I start with it. I do it for about 6 weeks, 2 months maybe, and then I keep them on something, like Zaki wipes or hypochlorous, because they're gentler and like well tolerated. And I don't know if tea tree for sure has damaging effect, and I don't want to take that risk, right? So I'll start with them, but long-term maintenance, I'll keep them on something that's safer long-term.
Got it. Perfect. Excellent. Okay. I want to talk a little bit about like you life-wise, like outside of clinic, let's say, or like work-life balance type of deal. You have a family, you're speaking at conferences. What does that look like for you? Like, what's your week-to-week, month-to-month kind of schedule? How many days are you in clinic? Working on the business, or speaking at conferences and that kind of thing.
So when I first opened my practice 12 years ago.
12 years?
12 years ago, okay. Yeah.
It's a long time
in 2013, so almost 12 years ago. I was working 7 days. Oh, I was there every day, working on the practice, seeing patients. I was also working at the school as an adjunct faculty. So I was doing a lot at Pacific University. Yeah, I did that for almost 10 years. And so initially, I was supplementing my income from outside of clinic, and as I was waiting for my clinic, I was building up my clinic. So I put in a lot of hours in the beginning. So I'm fortunate to say that now I only work 2 days a week. So I'm only seeing patients Mondays and Tuesdays, but they are jam-packed. I mean, I am exhausted at the end of those days, because these are 90% dry eye patients. So, I may still do some refractions here and there, especially if they're dry eye patients who need that. But essentially, I'm seeing very complex, multifactorial dry eye that I'm really working. My brain is working on overdrive. Like I get home and I can't even talk anymore, So those are, very sort of efficient, effective days. And then Wednesdays are my driving my kids around day. Chauffeur Wednesday, Thursday, Friday, or are my travel days. So again, I do travel for speaking, which I really enjoy. And I love doing this and really connecting with colleagues and, learning myself as much as I teach. And, but yeah, so it's kind of helped to have that balance. But I mean, I can't take credit. You have to have family support. So my husband is very supportive. When I'm away, he's doing all the work, taking care of the kids, driving them, school pickups, after school activities, and making sure there's dinner. So it's amazing. A lot on him. And so I really appreciate, I'm lucky to have a support system that allows me to do what I love.
I love that.
But I try to be home. Again, before I say yes to anything, I have my kids' school schedule on my calendar. and I have to work around them. So I still put them first.
Good.
And if I have to miss it, I make sure that my husband is there. So we try to, again, make sure that we're there for our kids. And
that's wonderful. Super mom.
Yeah, no.
Love that. Boss woman.
I wouldn't be able to do it without.
Super doctor. You're amazing. No, it's incredible.
Thank you.
Last thing I want to, a little bit off topic, but not quite. You know, you're overall a very healthy person, right? You keep in really good shape. Look at these guns. Can you flex with the camera for a second? Look, if you're watching on YouTube, look at these guns. You're jacked. Okay, but look, I see you wearing the Oura Ring.
Yeah.
Right? I see you have the continuous glucose monitor.
Yep.
So tell me about these things. How will you track like your health and these types of metrics, and how useful has that been on a personal level for you? Yeah,
I think, you know, well, you don't know, but some women in their 40s, we go through a lot of changes. And I've always been in a healthy mindset, you know, making sure that I, you know, exercise, eat healthy, sleep, and all those things. But when you are in your 40s, for a woman, there's a lot of changes that happen, and they happen silently.
I see.
And before you hit perimenopause or menopause, there are things that you're starting to see. The foods I used to eat, now I see are spiking my blood sugar. I see that there are certain patterns that I have to follow to make sure that I don't have these spikes. Sleep, stress, other things, you know, my cortisol levels really impact my glucose levels. So it's not just about diet, it's about, you know, all the kind of balancing. So if I'm traveling, if I'm doing all these things and I have a lot on my plate, I have to make sure that I'm not burning myself out, and I have to make sure that, okay, what's happening inside is going to work with it, with all the external stressors and you know. So, you know, for my HIV, my heart rate variability, that's really important because, again, as you know,
sort of a new metric that I think, I don't know how many people know about heart rate variability or how conscious they are of it, but I feel like that's sort of a new metric that's coming out for kind of your own just overall well-being and health, right?
Yes, and it really gives me a lot of insight of what's happening with my sympathetic and parasympathetic nervous system, and am I imbalance? Am I, you know, or am I exerting myself? You know, again, sleep plays a role, alcohol plays a role, how much, you know. So there's a lot of different things. It's basically constant feedback, biofeedback to me on knowing like, hey, I need to pay attention to this. This seems a little bit off. Let me slow down. Let me, you know, say no to that. Let me say, you know, again, just kind of having boundaries. And so again, I want to age healthy, right? I want to age healthy. I don't like the term anti-age because we should be aging, right? We should be aging, but we should be aging with good energy, you know, with vibrancy, and, you know, and just being our best self still, like at whatever age we are, right? So that's kind of
the health span instead of lifespan is what we should be focused on, right? Is just being healthy as we get older. Is that something you suggest, a continuous glucose monitor, just in general? Like, I've been thinking about it for a long time, and just go buy one from the pharmacy and use it, and, you know, measure that for myself for a couple of weeks just to get an idea. Like you said, if you don't know, like just like in a business, if you don't know what your numbers are, you'll never know how to get better. So I don't know, I can guess, but I don't know for sure how much this food spikes my glucose or this one does. You think that's something that like just average person can benefit from?
Absolutely. Yeah. I think every single, and you'd be surprised. Again, I've been wearing mine for over 2 years now.
Really?
Yeah. And there's still some fine tuning that I do, and there's still some things that I'm surprised, you know, how that, so again, I think my body's going through changes, so that really affects how my blood sugars will change throughout. And for you, you may just do like a couple of months, 3 months sort of trial and be like, I already know, like I'm good, and not have to do it again. I find, again, for me, I almost like feel naked without it now. So it's always something that I feel like, all right, mornings, you know, monitoring it in the mornings, and with the fasting.
I gotta get it. So I recently got this, it's called Whoop. Have you heard of Whoop before?
No.
Okay, so similar concept to Oura Ring, but it's just a bracelet. But same idea. So only about a month I've been checking my HRV and other like sleep metrics and stuff like that, but I want to get more into it for sure. And so I think I'll get the CGM as well soon, because I like, you know, for sure I get like obviously differences as far as changes that our bodies will go through, but my body's, in the last few years as a 40-plus-year-old man as well, definitely changing.
Yes.
I don't react as well. My body doesn't react the same way to exercise as it used to.
Yeah.
And I know for a fact that certain foods are having different effects, but I haven't measured it.
Yes.
So I think the CGM is going to be a good way for me to see that, that meal that maybe normally I thought was not that bad, maybe is not as good as it used to be.
Yeah.
And I don't know unless I check. So I
Yeah.
appreciate that. Thanks.
Yeah.
I'm going to let you know. I'm going to post about it.
Good.
And I'm going to let everyone know that Mila is the one who finally got me over that to push me over to get the CGM. Okay. So I'm going to ask you one more question at the end as our wrap-up question. But before that, how can people get in touch with you or learn more from you or learn about you're still doing the nutrition stuff, the program?
Yes.
Yeah.
Yes.
I Thrive, right?
ithrivewellness.com, and we have a program for patients. So if you have patients that need that nutritional support, but you don't really know where to send, they have dry eye, you want them to actually know what to eat and what to take, what supplements and things like that, so they can actually have a self-paced program, and they have access to me and to Dr. Celia Futch, the other optometrists and nutritionists who I've partnered with. So they can, that's one option.
So that's the patient portal or patient one?
Yeah, patient
I Thrive
program.
Wellness, EYE-ThriveWellness.com.
Okay. And then we also have education for eye care providers. So we have a module that on gut health, so we really dive in deep into it. So if you have the passion and interest to really learn about this and be able to make that connection and discuss it with your patients, this is a great program to, again, it's self-paced, so you just kind of take it as on your own, so there's not like one-time thing. So that's another option. And then, just follow me on iDr Mila on Instagram and message me. I get messages a lot about, just asking whatever clinical questions or like, where do I learn this? How do I do this? And things like that. Also, consider joining Ocular Wellness and Nutrition Society. So there's and I'm a fellow of the society, and so is Celia, and it is something kind of how we started with nutrition. So there are a lot of resources. There's a program that they offer through the American Nutrition Association. So again, webinars or some in-person lectures and things like that. They're going to be at the academy.
Okay.
So that's a good place as well.
Great.
Yeah.
Ocular. Sorry, what was the organization again?
Ocular Wellness and Nutrition Society.
Ocular Wellness and Nutrition Society.
Yeah.
Got it. Great. Okay. So last question. This is a segment. It's not that new anymore, but I keep saying it's a new segment that I'm trying to like make it happen. So it's called You're Welcome. Have you seen Moana?
Yeah.
Okay. So Maui.
Yeah.
And he's a song called You're Welcome.
Yeah.
Right? He's kind of egotistical and saying, You're welcome, you're welcome.
Yeah,
okay. So the idea here is I'm going to ask you to share some profound, important piece of advice or a quote or something that you think is going to help us to be better in our lives. And then I'm going to say thank you and you're going to say you're welcome. I'm going to give you a second to think about it. So let's do You're Welcome. You're welcome. You're welcome. So, Dr. Ioussifova, what amazing piece of advice can you share with us today?
You can grow if you are in your comfort zone. So in order to grow as a person and as a doctor, you have to push yourself to go outside of your comfort zone, whether it's taking steps in, practice, in patient care, doing something that's outside of, the norm, but go lean into your discomfort, welcome it, and that's where you're going to find growth and potential.
Absolutely. Absolutely. Growth starts, how's it saying? Growth starts at the end of your comfort zone or something like that, right? Amazing. I love that. Thank you.
You're welcome.
You're welcome. You're welcome. Okay, good. Perfect. Thank you so much, Mila. I really appreciate this. It's so great we got to do this in person. You're just so great. You're so sweet. You're such a nice person. And honestly, for the profession, you're just doing so much to help push those boundaries, push our comfort zone so we can keep growing. So thanks so much.
Yeah. Thank you. Thanks for having me.
Yeah, my pleasure. Okay, and thanks for listening and watching the 2020 podcast, Canada's #1 optometry podcast. We'll see you guys in the next episode.